So I always start my presentations with a little bit of the history of Leigh syndrome. I find it fascinating, and I think a lot of people don't know about it. So Leigh syndrome was originally described by a doctor, Dennis Leigh, in England. And the story is that there was a 7-month-old boy who had been previously healthy, and his sister was sick with a respiratory infection. And all of a sudden, his mom described that he stopped crying and stopped eating. And she became very concerned, and she brought him into the hospital in England, and Dr. Leigh was on call. He went on to become a psychiatrist. So he was sort of studying the brain, but not really neurology per se. And he took care of this child, and the child became very ill and died 3 days later. And this was back in 1951, I believe. Yeah. And Dr. Leigh didn't understand what had happened, and he performed an autopsy. And what he found were some very unusual findings in the brain of the child, showing midline symmetric lesions that he couldn't explain. And because he couldn't explain it and he didn't understand it, he wrote a paper about it. And in medicine, that's often the way that we communicate our findings, especially before the internet, to each other. Thank you. And so over the next 50 years, more and more people, I can't see that, more and more people started writing papers about similar cases. And again, this was the way that people communicated with each other, physicians communicated with each other, and we started realizing that this was not just an isolated case. There were more and more children that had similar brain injuries. And eventually physicians started recognizing that a lot of these children had elevated lactic acid and started putting together that there was mitochondrial dysfunction associated with this condition. In the 1980s is when MRI scanning became available clinically, and people started being able to image children when they came in and they weren't responding appropriately. And so we started being able to identify children with Leigh syndrome pre-mortem and started recognizing what was happening when they were coming into the hospital. And again, it has just really skyrocketed the amount of information we've understood, the cases that we've been able to recognize in our treatment paradigm for Leigh syndrome since the 1980s. So some things that we know now, many pregnancies and deliveries are normal, but about a quarter of the patients have some sort of abnormal signs at birth. They can either have problems with their tone, they can have problems with their heart, elevated lactic acid, feeding problems or low blood sugar, high bilirubin, or sometimes even seizures. About 3/4 of children will have some kind of developmental delay or feeding problems. This is contrary to what we used to think, which was that everyone was healthy until their first onset. Now we know about 75% of children do have some early signs of problems. So about 25% of patients will present for the first time during an acute metabolic stressor. 25% of patients will have normal lactic acid levels. Again, I hear over and over again when I'm seeing a patient for evaluation that they were told they couldn't have Leigh syndrome or their child couldn't have Leigh syndrome because they didn't have an elevated lactic acid. Half of them have normal muscle biopsies. Again, this is often considered a disease of the brain. And so very frequently, if you have a muscle biopsy, it will be normal. There are a common set of neurologic symptoms we do see in children with Leigh syndrome. We'll see a lot of motor dysfunction, so problems moving the muscles, a lot of low tone, especially truncal tone, so difficulty with the head and the trunk sitting up, being able to support yourself. A lot of what we call restless movements. So the areas of the brain, and I'm going to go through these in just a second, that are affected, part of it is the basal ganglia. And so one of the things that's very common is something we refer to as dyskinesias. These are excessive movements or an inability to control some of these extra movements. And one of the things we see is chorea, where you'll see this kind of, it's almost like a dancing movement or just a movement. And children will often look like they're restless. And that's something that I think is under-recognized and under-treated in children with Leigh syndrome. A lot of children will have poor balance or ataxia. There is some cognitive impairment and or decline. Most children with Leigh syndrome, or a lot of children with Leigh syndrome, are believed to have normal cognitive function. I believe that the basal ganglia, the midline structures that are involved, are not the quote thinking areas of the brain. But the more that we learn about it, the longer our children are surviving. I do believe there is some degree of cognitive involvement or cognitive decline that is seen. And again, these are just generalities, not specifics. A lack of movement or slowing is something else that's very commonly seen. The basal ganglia are affected in Parkinson's disease, and people with Parkinson's disease have a paucity of movement, not enough movement, something we call bradykinesia or slowness. And very commonly, the children and adults with Leigh syndrome will develop this bradykinesia. You'll see they talk slowly, they move slowly, they develop a shuffling gait that's very similar to patients with Parkinson's disease. And that's something that's seen very commonly. Muscle spasms and dystonia, again, are a very common feature of Leigh syndrome. And this all has to do with the parts of the brain that can be affected. And then brainstem dysfunction. This is one of the most life-threatening and serious complications of Leigh syndrome. The brainstem is important for the autonomic functions that Dr. Grotman was just discussing. These are the automatic things that happen in your body. Things like your heart rate, your breathing, all of those that happen to us all the time, and we don't even think about them or realize they're happening. Your heart beats all on its own. It speeds up all on its own and slows down depending on what you're doing. A lot of these relays are controlled in your brainstem, and children and adults with Leigh syndrome have damage that occurs sometimes to that region of their brain. And when they do, it can affect the autonomic nervous system. And we can see fluctuations in things like the heart rate or dysregulated breathing because of those areas of damage that occur. So just to show you some of the areas, these are a series of MRI scans from some patients that I have with Leigh syndrome. So the white area is what the area the blue arrow is pointing to. But on the left, the very bright areas in the middle, on the right, the area where the blue area is pointing to, you see this is the midbrain. And this is an area that's been damaged in this patient. The midbrain is responsible for sleep, wakefulness, alertness, and temperature regulation. This patient had a lot of trouble remaining awake. They slept a lot. They had a lot of sleep time. And it was interesting, you would see that again in Leigh syndrome, just like a lot of the mitochondrial disorders, these symptoms fluctuate. There are periods when they're a lot worse and periods when they're a lot better. Right after this crisis, this person was sleeping about 20, 22 hours a day. That's better now. The lower brainstem and the pons, again, the white areas on the left side of your screen and the arrow on the right side of your screen. This is the part that controls your autonomic functions, the regulation of breathing. Eye movements can also be involved, chewing and swallowing, bladder control, all of those things can be involved there in the pons. The basal ganglia, again, Dr. Grotman talked about this. These are a relay section of your brain. It's where the motor function goes from the periphery to the cortex. Everything has to go through the basal ganglia. And so the basal ganglia help control how that movement occurs. And so oftentimes when you have dysregulation or damage to the basal ganglia, there will be a problem with movement, either too much movement, the dyskinesia, not enough movement, where you get the paucity or the bradykinesia, or you get irregular movements or dystonia, things that you can't control. The thalami, this is your sensory relay. Again, your control from the body to the brain. The periaqueductal gray matter also is very much involved in the autonomic function, and we can see that involved a lot in Leigh syndrome. And then the cerebellum. I always feel like the cerebellum is neglected in Leigh syndrome. It does get involved in a lot of patients. It is very much responsible for balance and posture. And a lot of patients with Leigh syndrome will have ataxia or difficulty, again, with their balance because of cerebellar involvement. And then the white matter. Again, we think of Leigh syndrome as this bilateral symmetric midline, and people forget that white matter can be involved as well. So Dr. Grotman was talking about the myelin that surrounds the nerves that allows those connection between the nerve cells to go fast. That's the myelin. And a lot of patients, certainly not all, but a lot of patients with Leigh syndrome will have involvement of their myelin as well. And they'll have some white matter episodes that occur. And so they can have some disturbance in the cortical functions. So this is where it comes down to the cognitive involvement. So when you think about these midline structures that we've been talking about, these all have to do with motor skills and autonomic function. And they don't have to do with what I refer to as the thinking part of the brain. And so mostly patients still have this cognitive ability. And I love to talk with the Leigh patients. I love talking with them, even if they can't talk back to me, because there's no doubt that they're in there and they understand what you're saying to them. And they love to interact. They love to participate in conversations with you. But a lot of them do have some white matter involvement, which can affect some degree of their cognitive function, at least somewhere in the course of their disease. So we know that the outcome still remains poor. Most patients will ultimately succumb to brainstem dysfunction. We do know, however, that early diagnosis and careful watching during febrile illness has led to many children surviving longer. I think if you take nothing away from this session today, please remember that we are doing our best to understand the natural history or the prognosis, the course of disease in Leigh syndrome. I think that we don't know that right now. I still remember patients coming in, it happens to me still, and they say, my child was diagnosed with Leigh syndrome. I looked it up online and it said they would die by the time they were 2. Well, that's wrong. We all know that. But what we don't know is what the natural history is. We don't know what exactly the prognosis is. It makes it difficult for you as parents. It makes it difficult for us as physicians. And so one of the things that I think is crucial right now is really understanding what that is. We do know that at least 75% survive more than 3 years after symptom onset. And now I'm going to turn it over to Dr. Falk.
Thanks, Mary Kay. Good morning, everybody. Really a pleasure to be here and to see both the doctors and the families up so early. Like you don't have enough to deal with. We scheduled this super early, but really grateful that you're here. I'm a geneticist. I'm always humbled by the neurologist. I always love the arrows, just like you. I always feel like those are for the geneticists in the room. And I never even looked, formal disclosure, at the MRIs. I just read the reports like you guys. And there is this fear among families, like a big fear about looking, right? Like you don't want to know. So for about 10 years at CHOP, I didn't force anybody to get an MRI because of the sedation risk. And now we can get MRIs without sedation. And it's still like, oh my God, why do I want to know? But maybe we could talk about this more at the panel because I think the neurologists have a lot to weigh in. I actually think knowledge is power. And if you don't know the source of where a problem is coming from, it could be lots of things. Balance could be lots of things. But if you knew it was a cerebellum, and I think the other amazing thing is that the kids' brains are so resilient. And again, I don't know why, but these things go away sometimes. So that's also a super great thing to know. And what gives me a lot of hope about therapy, which we'll come to. So what is a primary mitochondrial disease or a secondary mitochondrial disease? I have my little cartoons here, which I'm very visual, so I prefer that over all the words. But in the primary mitochondrial disease, the source of the problem, what's causing everything to go wrong, is the mitochondria. The mitochondria is where the problem starts, and then everything else in the cell and in the body, is disrupted. But the problem is because of a gene that makes something, a protein, an RNA that functions in the structure or function of the mitochondria. It could be a nuclear gene, it could be a mitochondrial DNA gene, but it's making something that makes the mitochondria work. More than 95% of all mitochondrial disease genes, the cause is a gene that makes something in the mitochondria. Could it make something outside? Yes, but it's just not, that's not more common. And a lot of these diseases, and a lot of you know this from the COVID experience, are kind of stable until there's a stress. They fast, they have an anesthetic, they're sick, So there's this lot of like, well, do we put them in a bubble? Like, what do we do, to prevent this stress? And I think we're learning a lot about that too. So what's secondary mitochondrial disease? Well, the mitochondria aren't working. But the cause isn't in the mitochondria. They're like the innocent bystander, like this poor little baby with a dart on their head, right? Like they're not the problem. But once they're hit, like it's not awesome, right? Like once they're not working, they're not working. And there's a lot of people, the UMDF and a lot of scientists who say in their grants, well, if we can solve Leigh syndrome, we can solve Alzheimer's, right? And that's probably true to some degree, but I think the passion of the people here in the UMDF We're not trying to cure Alzheimer's. We're trying to cure mitochondrial disease. And I actually think, I'm so sorry this room is filled at all, but I wish it was filled more with the Leigh syndrome families, because I think it's by banding together that we've been empowered to figure all this out. So what's the genetic inheritance? Like if your kid has mitochondrial disease, what's the likelihood you have it or your next kid will have it? It depends. Depends if it's a mitochondrial DNA gene. Boys and girls can get it. Only girls can pass it on. Remember, boys can be affected, girls can be affected, and then you can go up generations and they can be affected to different degrees. I was talking with a family last night where the child could have such a severe level of a mutation for the mitochondrial disease, they have Leigh syndrome. And the grandma has such a low level, she goes deaf and she gets diabetes. And nobody quite realizes it's the same spectrum of disease. So we look for things in mitoDNA disease like fatigue, migraines, sometimes mood disorders, things that are nowhere near as severe as Leigh syndrome, but they clue us in that it might be a mitoDNA disease. But then a lot of the Leigh syndrome, probably the majority are nuclear genes, has nothing to do with the mitochondrial DNA having the problem. There's a gene making something that goes to the mitochondria. Most are autosomal recessive. A lot of the knowledge actually came from Australia and Dr. Thorburn's group, where they actually started to figure out how likely any one of these disease genes are or causes. So recessive is kind of like the classic Jewish genetic diseases, cystic fibrosis, sickle cell, like everyone in the family is fine, but the parents happen to each carry a mutation in the same gene, 1 in 4 chance the kid gets it, right? And that's a 1 in 4 chance with each pregnancy. Autosomal dominant, that's a nuclear gene where we all have 2 copies. Somebody has a change in one, 50-50 chance, flip of a coin, they pass it on. So they either could or couldn't, and it could skip generations. So that's another tricky, sometimes disease to predict. And some are X-linked, like Fragile X, not a mito disease, but it's a very well-known gene that's carried on the X chromosome, typically affects boys more severely than girls. I like to say girls are pretty cool. We have 2 X's. We tend to shut one off if that's the problem one. Boys aren't that lucky. Their Y doesn't count. So X-linked genes show up more in boys. And then there's sporadic, which means pretty much we don't know, not really a cause, and we're trying to get past that. But this is another reason why it really matters for the whole family that we figure this out, and actually for the patient too. It's very possible a patient will have a mito disease they cannot pass on. That's or the siblings might say, oh, I don't want to have kids. No, look what happened to my sibling. But there may be like 0 risk for them to pass it on if we knew what the cause was. So the general teaching is this idea that when you're really little, like when you're born and you have something wrong with your mitochondria that's genetic, it's a nuclear gene. And then if you're old, like a grown-up or older, it's a mitoDNA gene. And this used to be thought to be like 90% one or the other, depending on your age. Nothing's that extreme. It's probably like a quarter, 3/4, or a third, 2/3. The genetic testing is so much better than it was that we can actually find the causes now. So we have plenty of babies with mitochondrial DNA diseases. And we have plenty of adults with nuclear gene diseases. So this is a rule of thumb in like all of them. You can keep it in mind, and it's a good place to start, but it's by no means, will get you the right answer. We published a couple years back, really our view of how to get to diagnostics. And I'm sorry, this is small, maybe just because I don't have my glasses on. Hopefully you guys can read this. I thought this would be a little bit bigger, but basically, and we can certainly share this paper and of course all these slides with everybody. It's been a long road to understand how to diagnose mitochondrial diseases, and this applies, of course, to Leigh syndrome too. Things used to start with a clinical description, and they still do a really good clinical evaluation. Then they went, like Mary Kay said, to labs and biopsies, right? But the problem with muscle biopsies is sometimes early in life, there's no problem. Right? It just takes time for you to see the problem, or there's not a lab that necessarily does the right testing and the full testing doesn't get done, or nobody actually remembered to look at the mitochondrial DNA. So doing the whole suite of testing might not have happened, right? So maybe they just looked at it under the microscope. Little kids very seldom have something truly obvious when you look at it under the microscope for mito disease. Adults, it's a lot more abnormal. And so there's a lot more yield to just looking. But for little kids, you want to do biochemistry. Dr. Cohen had taught me that, more than 20 years ago. We had a whole group in Cleveland that would look really detail the biochemistry, and it would be the enzymes that might be abnormal, right? And then why are they abnormal? And then it's back to the genetics. So skipping ahead 20 years, really the right way to start is with labs and non-invasive things, and genetics. So the genetics has gotten so much better. I remember probably what got me into this was a little girl with Leigh Syndrome in Youngstown, Ohio, right, who was living on a ventilator because she had stroked her midbrain or brainstem, and she couldn't breathe on her own anymore, right? She had lost the ability to just breathe without thinking about it. So she had to live on a vent, and the doctor walked in and said, "I know what your child has. Their complex 4 in their mitochondria is not working." And the mother said, "Why?" And he goes, "Oh, we don't know." And that child died because you can't live on a ventilator. Now, again, there's home ventilators and you can, but back then you couldn't, and you get infections, and it just, it wasn't sustainable. And that mother never knew why her child died. And that just always bothered me. Like, how could we not know, right? So a genetic test today, in a week, depending on how rapid you could do it, gene and however much money or insurance you have, you can get the answer, which is like unbelievable. Then there's ICU groups now, in the NICU and the PICU who can do these tests, some of them in days, right? But in general, within a month or two, we can solve now what we could never even understand before. So it's just wonderful that we're there. So genetics is the right way to start. And I'm on the biggest bandwagon that children are parts of families. And the best genetics are when we look at the whole family, right? Because you might find a change and you don't know, was it in the mother? Was it in the father? Was it inherited both ways? So we always think about trio, child plus both parents is ideal, or quad, if there's another sibling affected. It's the best and quickest way to get to diagnosis. And we pushed really hard for the world not to ignore the mitochondrial DNA. Right? It's a chromosome, right? Why should it be picked on and thrown out and ignored? So we got GeneDx to just include it. So if anybody gets an exome, as long as your doctor checks the box, there's no extra cost. At CHOP, we've created a new test where when we send the kid's exome, the kid's mitochondrial DNA or exome, and you just check a box, they'll do the mother's for free at the same time. So you don't have to like fight insurance, which is a burden on everybody, right? To then say, well, does the mother have it or not? How do we understand this? So genetics is what you should take away. Do we ever go to biopsy? Yeah, we do. Why? We might find a variant we're not sure. We might not know exactly how severe it is, and we kind of want a better understanding. Or they might just be having some other procedure done, and we have the opportunity, and at that time we want to learn. We may not want to learn at another time. And then well, now that you have a genetic diagnosis, now you can get into clinical trials, right? And that's a big deal, right? Because that's where therapies are coming, right? Some of you might have heard our infrastructure panel lesson. I'm just going to repeat a few of those slides here in case not. So around 2012, we saw clinical exome was about to launch. So we need this huge amount of genomic data, but not necessarily knowledge about what it all meant. So we thought we should start putting together places for the community, the geneticists, the neurologists, to communicate on the features of the diseases. So there's more than 200 different disorders, and you can break them down to what are the components and define terminology. What are the genes? What are the variants? What's known about it? And laboratories. How does a laboratory director know if they see a result, that variant does or doesn't cause a disease? So this is a resource for professionals that has been really a labor of love. A ton of people have volunteered. The UMDF has supported this. And it's really for the community, I think, to come together and better understand the genetics of the disease. We also realize that not everybody's a geneticist, and not everybody, thinks in terms of, genomic terminology. So what we did is about a dozen of us put together a compendium of the mitochondrial disease genes in a readable format. So each gene gets 1 or 2 pages. What are the features? What's the research? What's the treatment? What are the animal models? When was it discovered? What's the inheritance pattern? So now anybody can just turn and say, oh, okay, here it is. So when we did it in 2019, we reviewed all the genes that were published and in the major databases that people had just sort of somehow formed. And we reviewed 288 genes, 258 genes were confirmed to cause mitochondrial disease. And now we're reviewing for the next group, anyone who isn't participating, you're welcome to join us, 300 more. So it's a very rapidly changing field still. Of the 300 genes or so we know of, like half have been discovered in the last 5 to 7 years, right? So that I always tell families, if you haven't had genetic testing recently, it's time. We actually tell people every couple of years. The technology for a long time, I used to give if you've been to my clinic, I talk a lot about video games. I grew up, we thought Pong was pretty cool. Atari was kind of like our dream, right? I know, it's sad. And then we didn't even have an Atari. I had to go to friends' houses to play an Atari. And now kids have like Xboxes and all sorts of things. The technology for the first part of the 2000 teens was pretty bad. So a lot of the data that was generated was like, not really complete, not really reliable. The variants may not actually have been there. It might have been sequencing errors. Now in 2022, the technology is great. Like everybody's got an Xbox, right? But not everybody can play the same and interpret it the same. And I'll come back to that. So one of the things that we've done, and we did this for Leigh syndrome, what genes cause Leigh syndrome? And so we reviewed 113 genes. And when I say we, I mean we, like all around the world, the people in this room, people in, what was it, like over 50 experts from around the world and like 11 countries on like nearly every continent that has man and women. I think we didn't have Antarctica. We're participating. People really cared and have been dedicating their time. And we have 111 genes that cause Leigh syndrome. That's really important, right? Because, that mother sitting in that ICU 20 years ago, right? We didn't know any, right? That's like an enormous change. And even things like Rye syndrome, which you might have heard back, aspirin causing things or certain types of infections, that was probably Leigh syndrome too. So there probably were other things that could do this. And that's very different if from a genetic disease. So right now, we finished the Leigh syndrome curation, and this group of, now it's 47 experts in 14 countries. And we have you don't see it, it's behind the scenes, but all the laboratories, they've been volunteering with us. They really wanted, when they write out your report, they really want to be accurate, right? They really want to know. And the FDA is starting to get to the point where for a laboratory to be able to report out a gene or sequence it, it needs to be like a confirmed disease gene. They can't just make it up, right? And so we put this information into the databases that the labs could use to then help the next family get diagnosed. That's why we try so hard to make it accurate. And now we're moving on to do all of primary mito disease, not just Leigh syndrome. But we started with Leigh syndrome. Oh, this is if you go to this is public. If you go to what's called ClinGen, it's this big NIH-funded program to kind of clean up all the genetic data in ClinVar, which is a public database that all the world uses that had a lot of kind of garbage in it. If you go into it, you can see, did a lab deposit the data or did the experts review all the literature? And this is, for example, you can go to any gene in this table that's online and you can see what's the evidence that that gene does or doesn't cause Leigh syndrome. The coolest thing, we've been wanting to do this forever. When I used to come to this meeting, families used to say, oh, I had genetic data here. Will you look at it? But if you've ever looked at a genetic data file, it's like a phone book, right? It's like totally uninterpretable, right? It's like A's, T's, C's, G's, it's random, right? And now they're huge because you can get the whole genome, which is all the nuclear genes plus everything else in the genome. So it's about 3 billion base pairs, right? It's like terabytes of data. It doesn't really fit on a flash drive anymore. So how do we share? How do we look? And then if you had it done at a lab, in 2016 and nobody's looking at it, maybe the data answer is sitting there and nobody's looked. And as a matter of fact, we pull back data on every one of our patients that gets done clinically. And about 10% of the time we can solve it just by looking. Because the clinical labs are a little bit, have their hands tied behind their back. They're allowed to call out genes that are known to cause disease. And in the research setting, when we sign you to a consent, we could look at those. Sometimes it was missed, but sometimes there's genes that haven't yet been recognized, but we know they're like the sister gene of a gene that does cause Leigh syndrome, so we can solve new genes. So that's part of why looking helps. This is pretty amazing to me. We've been trying to figure this out. You guys probably know about HIPAA and data privacy, and the families want their cases solved, and the world is not set up to support that easily, right? To transfer data, but now we can do it, and this is about to go live. So if you enroll in Mitoshare, you all know what Mitoshare is, right? It's the new patient advocacy group registry, which is pretty amazing. That launched in March. In January, we got IRB approval through CHOP. I'm the PI, so that when people will have the option to select that they have genomic data, like you had it done somewhere, a clinical lab, a research lab, wherever you had it done or whatever you had done, and you want to deposit it, you get connected to us. We have you sign a release online. We call the lab, we transfer it through the cloud, we scrub it, like it has nobody's name on it, and we'll tell you your ID is 1, 2, 3, 4, 5, right? It's just your ID. you tell people then to go in and look at it. So now there's a place that people can go, and they're not looking at a phone book. They're looking at a tool that, Dr. Mary Kay can go in and say, show me the genes in complex 1, or, you know what, I'm about to put on this medication. Can you actually show me the genes that affect how this medication might be metabolized? Like, does she have he or he have a variant that I should, do a pharmacogenomic kind of like adjustment of the medication? So that genetic data set becomes live. So that's going to go live. Look for it soon. And even if it's solved, I would definitely put it in, because sometimes, let's say the next family comes along and we find a variant and we're like, did that cause Leigh syndrome? And then maybe we'll realize, oh, these other kids had it too. That's a red herring. Or why are these kids with Leigh syndrome and SIRF1 so severe and these are so mild? Oh, there's actually another gene that's predicting that. So there's a lot we can do with the data, but it's now under your control. And this just shows some of the kind of like the Google versions of the tools that we've created for doctors and scientists. So families won't be mining the data, but they can give it to the doctors and scientists who can go in, and we're going to show them all how to do it. We have other tools too. This is a tool called Quick Mitome we've created for scientists and doctors, where they can upload your data file, and in 5 minutes it gets emailed to them, like which features you have, and then which variants in your genetic data might be causing the features. It's right about 70% of the time. Like the answer it solves, it's just a computer algorithm, is the cause of your disease. So the technology is getting better. We also have great tools for mitochondrial DNA analysis. If you find a variant, is it a disease-causing variant? Is it a sequencing error? So we put all the data together to help the doctors figure it out. And just the last few things to talk about are mitochondrial DNA is kind of quirky, right? It's like, I always talk about encyclopedias, like not Wikipedia, but encyclopedias, and that the nucleus has like one book of A and one book of B and so on. It actually has 2 books of each, right? The mitochondrial DNA doesn't follow anybody's rules, and it's like a pamphlet scattered throughout the cell, and there's hundreds and thousands of copies. So if you have a mutation in a proportion, well, what proportion do you need to be sick? And how do we know if we look in your blood or in your urine what it is in your brain? Right? And then how do we know whether if your kid has it, that your next kid will have it, right? And so these are issues of heteroplasmy. And some of this just comes back to the fact that eggs really should just be called mitochondrial sacs. Like that's what I think they are. There's hundreds of thousands of mitochondria in each egg. And the first few days, once you have fertilization, all that's happening is you're just dividing the mitochondria randomly. Like if you could picture a jelly bean jar, and some have the mutation and some don't in that mitochondria, it's just randomly splitting. The red are going to some and some and some. And so when you get down to like day 3 or so, and the cell that's going to become the baby, who could predict, right? How many of the abnormal versus normal jelly beans or mitochondria are in there? So, and then it's random. So it could be then that the precursor cell that becomes the brain is different than the one that becomes the heart, and so on. And so that's just biologic complexity, right? But now there's options. So there's in England, Dr. McFarlane's group, Granray Gorman, that amazing team, they're starting to do mitochondrial replacement technology. They can take a fertilized embryo 12 hours after fertilization and swap that nucleus out with another fertilized embryo that has maybe the dad's sperm fertilized a donor's egg. But there's no of the mutation present in the mitochondria, and to take the intended parents and put their nucleus in. That's happening. We haven't heard results. That's not allowed in America. That's still an advocacy issue we all need to work on. Sean Murray can tell you how amazing they just got it approved in Australia, but here there's a reason in some legal document that you're not allowed to do this here. But what you can do, and I really wanted to make sure I shared this with you today, you can do PGD for mitochondrial DNA problems that cause Leigh syndrome. That's a big change. Part of it is technology, right? The video game analogy, the technology to be sure that you understand the level of the heteroplasmy in each cell of that embryo has gotten better. Most labs in America won't do it. I actually don't know any lab in America I trust, right? But there's a laboratory in England, the same one that does the pronuclear transfer, and they were allowing families to travel there for something called PGD, just to tell you how much of the mutation was present in each of the cells of the embryo. And that's incredibly stressful. Like 1, you're going through IVF. 2, you have to schlep to England. 3, you have to stay there for several weeks and undergo procedures, right? And it was really stressful. So we figured out a way Took a lot of work and some wonderful families who went through this for us to figure out how do you keep the family in America and ship either the embryo or just the cell for the mitochondrial DNA test. We do it all the time for nuclear gene problems, but how do you do it for the mitoDNA? And it's working. So we just had the first baby born. She's 9 months old. And so it's a really big deal. So people that have a mitochondrial DNA cause for their baby having Leigh syndrome could potentially select an embryo that does not have the mutation or that has a sufficiently low enough level of mutation that they won't most likely have Leigh syndrome. And there's a lot of discussions and counseling that goes into this, but I think for the first time ever, swapping out the mother's mitochondrial DNA with somebody else's isn't allowed in America, but at least testing to see and pick, if there's 20 embryos and picking the one that's not going to have Leigh syndrome, that's a big deal. I think Mary Kay is going to talk about therapy, and maybe we'll save some of this for the discussion. There are guidelines now. There are standards of care now. Mary Kay is now big congratulations, the president of the Mitochondrial Medicine Society. She's one of the leaders in the Leigh syndrome community, and there are standards of care. We published an article, some of you may have seen this, with some of our fellows, reviewing what the medication doses should be for the mito cocktail, what components they are, what to think about, what risks and why we might try them. And I had put in some slides, I can share them with you, after if you're interested. There's a lot of therapies coming for Leigh syndrome. Just as an example, the Leigh syndrome, when the problem happens in the mitochondria, the rest of the cell becomes quite sick. And the adaptations that we're seeing in the rest of the cell aren't always helpful. And here I give the analogy where if you ever had your kid in a shopping mall, or you see, not yours, but you see a kid in the shopping mall and the kid starts screaming, like that's a problem, right? But like you walk by, right? But depending on the parent's response to that child screaming, things could get out of control. Right? So the response itself is really pivotal here. Same thing in the cell. The mitochondria is not working that well, right? And the cell's trying to fix it, but sometimes the cell's responses are actually making things worse. So some of this is just re-regulating what's happening in the cell. There is some therapies that are coming. There's some that are discussed now, there's not enough, but I'm convinced that there's therapies that will actually make a difference in the function of Leigh syndrome kids, and that we can go through together and start coming up with sort of ways to model those diseases and to start to test some of the therapies. And more importantly, test in, like, let's say your kid's cells. Well, if we have a therapy we think might work and it makes their cells die, well, we probably aren't going to go forward, right? Like that's pretty obvious, but important, right? And if it makes our cells better, well, that's pretty compelling that we should maybe try. So I think I'll stop there. Again, in the interest of time, I just wanted to leave you, I think this is my last slide here. This is a fish on your left, a zebrafish. They're microscopic fish. They're pretty cool. They're transparent for the first week of life, and we can see all their organs. And this is their brain, this lovely golden area. And if we give it a little bit of stress, that brain dies. But what's amazing is that we can take a range of different genetic disease models, SIRF1, some complex 1 subunits, FBXL4, DLD, like models of different forms of Leigh syndrome. We can prevent brain death. So we know they have a genetic model, and we can expose them to stress, and they can sustain it and not get sick. And they can not only not have their brain die, they can swim and they can respond. So that's one of our goals for Leigh syndrome, right? We know that they have the genetic change, but we don't want them to decompensate anymore. We want to build their resiliency in their immune system, in their brains, in their cells.
Thank you. How much time do we have left? Okay. All right. So I want to try to cover just a few practical things. That was great, Marni. Thank you so much. I do want to try to cover a few practical things about what to do in the setting of an illness, or what to do if something happens. So I'm going to try to get it all in the last 7 minutes. Okay. So a routine febrile illness is something that is scary for a lot of people who have Leigh syndrome or their patients. We talk about the metabolic stressor, and kids get sick. That's what happens. They're around other kids, they get sick. And this type of illness is something that can send them into a crisis state. It can stress their metabolic system and can send them into a metabolic crisis, which is what can trigger the damage to occur in the brain in a patient with Leigh syndrome. And so for our patients, particularly the young ones, which are children who already have a lot of metabolic stress, we do recommend that if they have a fever, anything over 101, that they go to the hospital and they get IV fluids with dextrose or some sort of sugar. Because what these fluids can do is they can actually trick your body into a metabolically less stressful state, and they can kind of shut off your mitochondrial system and try to prevent some of the complications that can occur in Leigh syndrome. And I'm not going to over describe that. If anybody has any questions, I'm happy to address them later. We do recommend that our patients stay in the hospital on fluids until their lactic acid levels have returned to normal, and they've been afebrile for at least 12 hours without anti-febrile agents. So a metabolic crisis, this is kind of what we're all afraid of. This is when it tips over that edge. So this is when you're placed under a metabolic stress and the patient starts decompensating. So this is when a Leigh patient will start developing the damage to the midline structures of the brain. If the brainstem becomes affected, this is when the autonomic system becomes involved, and a patient can start having a disruption of their autonomic or automatic breathing and cardiac systems. So this is why we put the patients in the hospital, because the highest risk for this is during a time when they are metabolically stressed. So I always say, if your heart's going to stop, there's no better place for it to stop than in an ICU or in an IMU on a monitor where someone can intervene immediately. And so we do recommend our patients come in and be on a CP monitor while they're febrile, especially when they're young and early in the course of the disease. So again, it's this concept that the febrile illness can lead to brainstem damage, which can lead to respiratory failure or cardiac arrest. And what we want to do is we want to modify the natural history of this disease. If this happens while you're at home, it is very unlikely that a child or an adult can survive this. But if it happens in a hospital setting, it is much more likely that someone can pull through or survive this type of setting. So I don't want to say that this is the only thing that occurs in patients with Leigh syndrome. We do know this is a neurodegenerative disease. Our patients are living longer and longer and longer. And one thing that has become clear is that even in the absence of metabolic crises, there is neurodegeneration that does occur. However, we know that immediate recognition and treatment of these crises can prolong life. And so that is something that we do want to do, and patients can display remarkable recoveries after these crises in some situations. Medications, this is another big issue that I think has gone on and on. There used to be a long list of medicines. For people who have heard about these lists of medicines, we used to always talk about, there were literally 40 medicines. Don't give your patients these medicines. And there was a consensus report that was published in 2020 about medicines, and it's now no longer recommended that you avoid all medicines or all medicines on this list. There's only a few medicines that are absolutely contraindicated, and one of them is valproic acid. Everything else is kind of used with a point of caution. And what that does is it allows doctors to use their clinical judgment. There are some situations where you absolutely have to use a medicine. It comes down to a choice of life or death, and it needs to be a clinical decision, not an absolute contraindication. So I just want to make sure that everybody is aware that that has changed. Okay, so developing your Leigh syndrome care team. It is very important to have a care team. You do want to make sure that you have a local group. So yeah, I think I'm reading your slide real quickly. I think we agree totally on this. Patients with a metabolic rare condition, something like Leigh syndrome, they should have a primary mitochondrial center where they have a home where they're visiting on a somewhat routine basis. But we know it's not practical for most people to receive all of your care there. It is really important to have a care team at home. You need to have your specialists, a neurologist, a geneticist, a metabolic specialist, an endocrinologist, a pulmonologist, a cardiologist, whoever you need, someone in your community who can take care of your child or yourself. We have patients that come from all over the country who come and see us on a regular basis, once a year, once every other year. We're able then to communicate back with their specialists at home and provide recommendations of care. This can occur on a day-to-day basis. It can occur when they're seeing them in the clinic. It can occur when the child is in the hospital. It's very difficult to provide specific recommendations for someone's care if we don't know them. So in order to achieve that almost personal one-on-one recommendation level for your child when your child is in the ICU, I actually need to know your child. And so I know that it is a burden and it is very difficult to sometimes travel to a mitochondrial center, but that is what's different. And I also know that there are centers like CHOP that are doing a lot more telemedicine now and are offering that service that is available to establish that relationship with the mitochondrial specialist. But it is crucial to develop a care team at home that knows you, knows your child, and knows how to take care of your child.
Yeah, so we could certainly answer more questions about this, but I think this is a big deal because this is still fairly rare, right? So we've seen a lot of people kind of like miscounsel because people might be reading some textbook from like the 90s or something, and or you get advice when you're in the ICU to like not resuscitate, right? And things that we would never convey. So I do think giving that back up to your local physicians is one of our goals. Educating them. We have a fellowship program now. We'll train anybody, cardiology, endocrinology, GI, whatever. Anybody wants to come, let us know. We'll send them. They can go back to their community and understand more. But I think clinical trial accessibility, we'll tell you about everything we think is coming, precision therapies. And then some people come to us, because we have somebody who's become very interested in like the cardiology piece or the retinal piece, or, so you might come and see them again, once a year, or the endocrine, it depends, on which conditions. But I think that's again why we see people ideally once a year. Technically, you're not a new patient. You're an established patient if you're seen once every 3 years. So just keep that in mind if you want medication refills and stuff like that. I think it's better. We often see little kids more often, just with Leigh syndrome. And then you probably know there's this period like after 2, 3, 4, where a lot of the kids are just more stable. Maybe they have G tubes, maybe their bodies are just more resilient. So maybe by then you don't need to see us as often, every year, every other year. But I think that communication really empowers families, right?
And that leads right into our next slide, which is the Mitochondrial Care Network. If you're not familiar with it, it was launched in 2018. It's a collaborative effort between the Mitochondrial Medicine Society and the US-based advocacy groups, MitoAction and UMDF. So it's a group of physicians at medical centers across the US that have expertise and experience in mitochondrial disease care, medical care. Currently, we have, this has gone now to, I don't know what the new numbers are. Do you know what the new numbers are, Bruce? Okay. Well, we have about 20 sites and a few affiliated sites now. So you can go to mitonetwork.org, and the goal is to have a mitochondrial care center close enough where everyone can go. I did also want to mention registries. There's been talk about all of this. A registry is a collection of information about patients with a particular condition. It serves two main purposes. Really, one is to connect patients with clinical trials or to connect patients with each other. The other is to learn more about a disease. And I'm not going to belabor this point. Right now, there are 2 Leigh syndrome specific registries. One is trials, and full disclosure, I am the curator for that registry. It is sponsored by PALS. Thank you, Lori Martin. The other is CORDS, which is sponsored by Cure Mito. It is important not just to join one registry, but unfortunately to join all of the registries. Obviously we're all trying to find ways to crosstalk, but until that happens seamlessly, it really is beneficial for the community to join all of them. And then there's also 2 main registries, the NAMDEC and the MitoShare. And then Dr. Falk just talked about how with the MitoShare you can join, what is
the genetic sharing,
the genetic sharing part. And then there are some natural history and interventional studies that are going on. Dr. McFarland has a Leigh-specific natural history study that was sponsored by the Leigh Syndrome Roadmap Project in England called LION. And then the mini study at the NIH is collecting information on metabolism, infection, and immunity. And they have a strong focus on Leigh syndrome. If you need more information, I know they have a table out there. The Mito-E study, I'm sure you've all heard of that now. It is the vatiquinone study for refractory epilepsy in patients with mitochondrial disease, aged 18 and under. And then Dr. Stackpole is running a study on dichloroacetate in children with pyruvate dehydrogenase complex deficiency. The International Natural History Study enrolling Leigh syndrome patients, we've already talked about this morning. This is the one being funded by the Leigh Syndrome Roadmap Project. Dr. Cohen mentioned it to start off. CHOP is the first site open. There are other sites that should be opening soon. This is a prospective study generating natural history information on children with Leigh syndrome. The main goal here really is clinical trial readiness. We need to understand what is happening so that we can prove to the FDA that the treatments that we're developing are working, if they are working.
So we're the data coordinating center. We're making the data available to anybody who wants it, of course, all the investigators and pharma and so on. Our CHOP patients, some of you may be enrolled. I think in the first month or two, we enrolled 14 Leigh syndrome patients already. We have over 150, but there's talk with families who have enrolled if they're willing to share with you, but it's incredibly enabling, but also it can be done remotely. So the assessments can be done, there's parts that the family fills out and there's parts that the doctors do, like dystonia, ataxia. So as opposed to registries where you have to just kind of summarize everything, every 3 months, there'll be an assessment, and it's been wonderful. The families they've been very eager to participate. And I think, again, this is one of those things that could be unifying because it could be shared with everybody.
Yeah. And because Margaret told me I had 2 minutes, I'm going to add to that. So, one of the things about participating in a study like this, a lot of people will say, this is a natural history study. My child gets no benefit from this. It's just, they're going to be there all day doing scales and it's going to be exhausting for them. And yet there's no treatment associated with it. But don't underestimate the additional assessments that your child is going to be getting from a therapist that knows about Leigh syndrome and is seeing a lot of Leigh syndrome patients. There are nuances that they may see during that assessment that could really help advance their treatment. In addition, the more patients that we see and the more that we understand about the movements and the physical aspects of this condition, the better able we are to design therapies to help your child. And so although you may not be able to on an immediate basis, today I walked in and my kid got a drug, see the benefit, there are enormous benefits that we are hoping are going to be readily translatable to your children.
And the other, I think, elephant in the room, that why this is so important, FDA is making everybody go back and do natural history studies, right? So either you have to enroll people who don't get the drug, or sometimes you could use a historic control, but there were no prospective studies. So that's happened with the gene therapy, I think for SURF1, they had to go back. This is including all the genetic information, all the prospective data. We're hopeful that this will build a community resource that the FDA could look at and be like, oh, look, like this is the natural history of the disease, not in 1950, but in 2020s. And now they could say, oh, look, this is where the problem is. So if your company has a drug, we're hoping this will expedite that. And we're watching again and again rare disease struggle with this. That's another reason this is so important.
And I think we're done.